Thanks so much for the opportunity to highlight some of the work that we did in Ontario. I'm going to really, with Mac, highlight ever so briefly, or we're going to try, some of the amazing work that our colleagues and peer researchers have been doing in a different provincial context. So our complementary work in Ontario over the last 5 or so years was an opportunity to consider what implementing a service like GCO would look like in a different provincial context, while also understanding a shifting STBBI testing landscape and ways to improve equitable testing for diverse groups of gay, bisexual, and queer folks. So in addition to fantastic co-investigators, I wanted to highlight the incredible people who were really the heart of data collection and analysis in Ontario, who are listed here. The outputs that we have are really the results of the leadership and critical community engaged work of this team, including incredible peer researchers who all have published or are working to publish first authored work from this study, which I think is really incredible. I'm also really grateful to Pranay, our first study coordinator, and to Mac for his incredible work on all aspects of the grant and really steadfast commitment to equity concerns across all phases of the work. I'm also excited to highlight the work of our really fantastic former postdoc, Kinnan, who's now a prof at York. And finally, want to highlight and celebrate the work of Ryan, who co-chaired our community advisory board since its inception. Ryan and the whole CAB has been really a joy to work with on this study. So we first convened the community advisory board in 2019, which met until March 2024. And this was a really critical aspect to our work in Ontario, an incredible group of 15 STBBI service users and providers, many who spoke in kind of both capacities, and was really integrated into all aspects of the study design and analysis, including us really helping to adapt to shifting STBBI testing contexts. So our team, working closely with Mark and Kathy and the larger national team, worked to engage in integrated knowledge mobilization throughout the study. So adding to what Mark already shared, you can see here key outputs kind of in the numbers, including 8 published manuscripts to date. So all of our open access publications and plain language summaries are also available on the study website. So please do check those out. And Mac and I will kind of briefly present a few of the key findings. So this is a quick snapshot of our study design and the key methods and sources of data for our work in Ontario. I'm going to start by highlighting some of the findings from what we call the context study. So in this work, we really wanted to understand what it would be, what it could look like to implement a service like GCO in a different provincial context. And this was an opportunity to combine implementation science with critical social science research. And we did this in the tradition of institutional ethnography to really kind of think about how we could conceptualize the provincial context. Next, we'll move to talk about what we learned from our acceptability research. Would this be of interest to our communities in Ontario? I'm going to start by highlighting some of the quantitative work. And this work includes questions that we embedded in the Sex Now survey between 2019 and 2020, working closely with a community-based research center. And then I'll turn things over to Mac, who's going to highlight some of our peer-led research qualitative work. So again, I can't do justice to all of the critical qual work that our team members led, but highlighting just a few examples of interest from key outputs. So I'll start with an example here. When asked to think about the difficulties that might emerge when rolling out GCO or another online testing program in the Ontario context, from their work experiences, one informant, an associate medical officer from a public health organization, explained discrepancies that can emerge between kind of quote unquote high priority IT project needs and city approval processes. So our participants really kind of took this on, trying to think through what it would look like to implement a service like this. It was explained that sexual health clinics may identify a new e-health program as a priority, but that moving through city processes can take several years before any new IT projects will be implemented. Informants interviewed in the Ontario context also talked about legislation in Ontario that governs procedures around who can order tests for patients. So it was explained that online STI testing was available in Ontario previously, but the Ministry of Health determined that this program wasn't compliant with the Laboratory and Specimen Collection Center Licensing Act, an act I did not previously know existed before we started doing this work. And so other informants talked in Ontario similarly that this legislation renders online testing complex and that an amendment to the act might be required before implementing GCO. Some key informants suggested other ways of moving forward with GCO through the Declaration of Controlled Acts, through the College of Physicians and Surgeons of Ontario, which is a legal mechanism through which testing happens in other settings outside of clinics, so in bathhouses or community centers. And so I'm giving these as examples ever so briefly to talk about the kinds of legislative and policy challenges that emerged as potential barriers or concerns in this different provincial context. And as things have evolved and we've seen the growth and availability of self-testing, which Mac will highlight in a few minutes, we've also seen other kinds of workarounds to address these legislative contextual issues. So with respect to the feasibility of GCO in Ontario, several informants discussed how the current political government, the Ford government, could be potentially interpreted as either a barrier or conversely a facilitator to implementing online STI testing. So for example, in April 2019, Ford's conservative government announced major cuts to the health spending in the budget. So in this analysis, it really forced us to look at these major contextual issues of budget cuts, of changes to health units, and the amalgamating of local health units. So this was an opportunity to really learn from informants as they discussed political and economic trends in the province and how it might affect efforts to roll out online STBBI testing. And so, for example, a nurse consultant with the provincial health organization explained how the shifting health units kind of ignites uncertainty about how sexual health will be organized going forward in this climate of austerity. And while we did this data collection years ago, many of these themes, as Mark and others have highlighted, are still really quite relevant. So this brings up questions of jurisdiction and legislation. And some informants explained that each local health unit may have their own protocols, guidelines, and regulations related to sexual health testing. I'll move on for time, but there's significant detail in these publications, both available open access, led by our former postdoc Kinnan, and I'd really encourage you to check those out. And just before I turn things over to Mac, I wanted to briefly mention some of the quantitative analysis that we've done, and a huge thanks to Joshin for his work leading this. And again, here we really wanted to understand the acceptability of an intervention like GCO among folks in Ontario. So the Ontario sample included 2,375 GBM who completed this acceptability question. The median age was 38. Most identified as gay, 75%, and 8 as transgender. So a third of participants reported no delays in testing for STBBIs. However, many did delay testing, with the four most common reasons being that they were too busy, inconvenient clinic hours, being too stressed, anxious, or depressed to get tested, and long wait times. And notably, acceptability of online STBI testing was high, with the vast majority of participants reporting that they'd either likely or very likely use this service. So that's really the headline finding I wanted to highlight here. And I'll just end by saying that many participants in this sample agreed that there are benefits to using online STBBI testing services. They thought it would help them save time and finding it more convenient than traditional sexual health clinics. However, the primary concern for many was around privacy and personal information. So again, please do check out this, this paper if you're interested in more of Joshin's excellent work. And I'll now turn things over to Mac.
Thanks so much, Daniel. So I'm going to talk briefly about the what we call acceptability study that basically looked at the feasibility of implementing GCO in Ontario. And that was through qualitative interviews with both service providers of STBBI testing and with GBQM who accessed STBBI testing. So we began our interviews in, that should say, June of 2020 until December of 2021. And they were virtual focus groups and interviews on Microsoft Teams and Zoom. We had 18 service providers and 38 GBQM or 2S GBQM who participated in our focus groups and interviews. And as Daniel noted, we used a community advisory board to help inform the study that we took our research back to, and were able to gain really valuable feedback from their thoughts and the discussions that we had in those meetings. And we used a community-based research principle to guide the study, which I found personally really helpful and really wonderful during the process of the study. And we had 4 peer researchers who were overall involved in data analysis and KT at the end, towards the end of the study. And we used a reflexive thematic analysis and in vivo 12 software to do the analyses. And we also use an institutional ethnography as sort of a guiding framework in a lot of our papers as well. And so for our service provider participants, we had 18 service providers, 3 focus groups, 11 individual interviews, just because people were busy. And you can kind of see here that the populations served from our service providers were GBQM, people with injectable drug use, transgender non-conforming individuals, sex workers, immigrants and newcomers, and youth. So we had quite a wide range of populations that our service provider participants did work with, which was gained really valuable insight from that. And they had really, really interesting perspectives because of the work that they did with these populations. And for our GBQM service user participants, we did a first round of interviews between June and September of 2020. And then we noticed during the course of our interviews that we really lacked Black and Indigenous participants, and we really wanted to make sure that their voices and needs were heard as well. So we were able to hire a peer researcher who identified as both Black and Indigenous, who did some really wonderful work to do a second round of interviews with Black and Indigenous participants only between September and December of 2021. Overall, we did have 38 participants in this group, 10 focus groups, and 8 individual interviews. Our age range was between 22 and 58 years old. 57% of our sample was white, 68% was gay, and 63% was cisgender. So what were some of our findings and some of our outputs from that aspect of the study? So we kind of had the, sorry, we had the very unique perspective of the COVID lockdown starting during the course of our data collection. So we're kind of in real time able to see the ways that COVID was changing sexual health services for folks. So that came to be really interesting in when we were doing our data output. So HeHo was able to put together a paper that basically talked about how COVID-19 affected the closure of sexual health clinics and how during the course of the study, they never really recovered from that. And here you can see a quote from one of our interviewees who said they were down to one public health nurse dealing with all the STBBI in their region. And even after that, staffing was half of what they used to be just because of all the redeployments due to COVID. And because of COVID, alternative testing models were found to be more convenient, safe, and accessible because people now realize that there were alternative ways of doing testing, especially due to the lack of resources within different public health units because of the COVID redeployments. So that was one really interesting finding that we had. A second really, I think, prevalent finding that we had from our service providers in particular was about communicating U equals U to the healthcare provider to their clients. So we kind of identified four key challenges, which was perceived challenges with the zero risk messaging, people not really wanting to receive sexual health information, skepticism, and more culturally appropriate resources. And out of that came a really great paper. We've had many different conference presentations that came out of our findings on the U equals U work. But I found that this quote from one of our frontline sexual health workers, they said, well, it's because U equals U is not 100%, it's 99 or whatever. So you leave a little margin of error and people will jump on that margin of error and say, well, there's still a chance. And you can't really argue with that. But then later in the interview, the same person said, but I'm proof that U equals U works. And they found that to be really helpful in their work as well. So that was personally very powerful for me to hear and see that and think about how that can change the way that we deliver the U equals U message. As I mentioned before, we did have challenges in recruiting gay, GBQM, Indigenous and Black participants. And thankfully, we were able to do more work and connect with more resources and people, including our community advisory board, and add more folks from those populations onto our community advisory board. And that led to some really interesting results and how race impacted people's testing. And so we have had a number of papers come out of those results as well. But we did find that a lot of people noted microaggressions because of their race, even outright hostility from service providers because they weren't white. There's a lot of discomfort that came from those people. And there's a lot more barriers that these folks noticed when accessing testing, such as they didn't see anything from their cultures in testing spaces. And so it made them feel alienated from the spaces that they were going into. And other things like distance, cost, and lack of privacy and confidentiality. And here someone said it's important for Indigenous and Black folks to see that this is for you and that is not just for everyone. And someone here, another really wonderful paper that was led by Abdi, our peer researcher. They said the space is so white. Sometimes I feel like there's a gaze. I think people look at big Black men with certain eyes in these spaces. I was able to really dig into some work around the experience of trans and gender nonconforming people within STBBI testing spaces. I know we're running short on time, so I'm not going to go too in depth, but people said that they've had really some challenges with providers being assumptive of their assigned sex, assigned body type, what genitals they had, and therefore they found it really challenging to get tested and saw a space like GCO to be a benefit to doing self-testing so you don't have to kind of lay yourself at the feet of an STBBI tester who might not understand your needs. And they overall just found these testing spaces to be really cis-normative and assumptive that trans people won't be entering these spaces, and so it made no accommodations for them. Um, and when we asked someone, why did you participate in the study? They said there's no safeguarding to testing for them as a trans person. There's no roadmap for them to navigate a testing space as a trans person. So what were the key benefits of GCO as noted by our participants? Here you can just see our chart. It's convenient, accessible, tailored to personal needs, facilitates access to other services like PrEP. It reduces judgment, anxiety, and stigma, decreases burden on the current healthcare system, and just more agency control and empowerment. Some key concerns around the use of a testing model like GCO was people not having access to technology, lack of accountability for people receiving a test result, lack of face-to-face interactions with healthcare providers, missed linkages to care, and labs were generally not perceived as being the most inclusive, the most welcoming spaces either. So there was some hesitancy around those spaces as well. So what have we learned and where are we going? So since we did the study, there's been a lot of innovation in the sector that was also ongoing during the course of the study. But one that really has stuck out as a similar model, if not similar, then in the spirit of GCO, which is Get a Kit. Basically, people enter in their mailing address and they get sent a kit to do self-testing. They offer HIV testing, but also in some jurisdictions, gonorrhea, chlamydia, syphilis, and hepatitis. But that's not in all of the locations, only in some of them. So we have seen new innovations that have gone around the barriers that Daniel noted from the laboratory acts and kind of the barriers that the government is putting in place. So what are our key takeaways from Ontario? Overall, people found that it was extremely acceptable to have a GCO-like model in Ontario, and people wanted it. There's an appetite for self and online testing in Ontario. It can help alleviate structural barriers and institutional barriers that people were facing due to minority status. People said it was not enough to simply provide online testing and it has to be complementary to in-person testing, and therefore we need to push the government to not defund in-person access and healthcare resources as well. There are unique legislative barriers to online testing in Ontario that makes things different, but people are getting around them, and we can see and model other things after the services that are now coming up and creating space in the sector. And finally, these new testing modalities need to be thought of in and developed in times of governmental austerity. I think that we can all look at the political climate and know that there are difficult times coming, and how can we continue to take the work that we did in 2019, 2020, and kind of project that out over the coming years. So I just want to end by thanking everyone who was part of the study. We had an amazing team, and most importantly, to all of our participants, because without their data, we would not be here. And I also want to thank you all for your time today. And I have mine and Daniel's emails on the screen if you want to reach out for any of the data that we presented today. But thank you so much.